chlorine or nitrogen and sulfur in the middle ring system. And you also see important electron withdrawing group at the 2 position that is believed to be kind of tying the protonated amine side chain to the right-hand side in this particular drawing, so they can mimic dopamine in terms of binding to dopamine receptors. So last time we were looking at the structure-activity relationships, and we have seen now the more potent, right, the tryptophan ethanol, right, which is more potent than tryptophan methyl, and then that is more potent than the dimethylamine on the side chain. So we were looking at last time perfenazine, which has the hydroxy and the chlorine at the 2 position. Hydroxy, of course, at the end of this side chain. So today we're going to be looking at a very similar compound. If you see, like at 2 position, instead of the chlorine, it's a trifluoromethyl substitution at the 2 position. And then if this R group is hydrogen, and that's basically tryptophan ethanol, right? So that's very similar to the structure shown above, which is the perfenazine. Structurally very much the same, and then its use is going to be mechanism-wise very much the same. So this is fluphenazine, and usually what you see is fluphenazine hydrochloride salt, because these are basic nitrogens, right? You can have HCl salts forming between the basic nitrogen and the HCl, the acid. So the half-life of this fluphenazine was administered is about 33 hours. About 33 hours, right? For the drug molecules, of course, it's used to treat schizophrenia, right? So this is a molecule that's used for schizophrenia with a half-life of 33 hours, and actually this drug needs to be administered multiple times a day. So we are actually looking at the oral injection, 3 to 4 times a day, even though the half-life is 33 hours, right? That's more than a day, but in order to maintain, I guess, steady concentrations of the drug molecule, they do give multiple times at lower doses, so they are maintained at a lower level, so you won't go up too high, may cause problems. But imagine how would you want to control schizophrenia in a schizophrenic patient, asking them to take the drug molecule, say, 3 times a day on a regular schedule, right? So that's going to be very hard to do. So that's why these two prodrugs kind of revolutionized the management of schizophrenia, right? Because this is what we are talking about in the 1960s and 70s, when we have the fluphenazine that has to be given multiple times a day to the schizophrenic patients and ask them to take them on a regular basis. But if you attach the fatty acid, in this case, 7-carbon fatty acid called enanthate, right? This is like 5 carbon plus this 6, and then you have a carbonyl, so 7-carbon fatty acid attached to this hydroxy. And then or you can have attached to this hydroxy a 10-carbon fatty acid. So this would be called decanolate, and then you have enanthate. So these are 2 prodrug forms of fluphenazine. So what are the fatty acids? Right? So they are carbon hydrogens. They are very lipid soluble, hydrophobic. So that means it doesn't like water. So when you have the fatty acid attached, and this is a very water insoluble compound, right? It's going to be more lipid soluble. So what you can do in this case is to suspend it in basically oil, right? So you can suspend it in oil and then inject it into the patient's, say, muscles, like in the area, deltoid muscles. So in this case, the drug molecules will slowly release from the injection site. Once it's released and leaked out from the injection site, it will go into the blood, right, the circulation, what you have in the blood, esterases. So what we have is these fatty acids attached to the hydroxy through an ester functional group, and that ester functional group can be hydrolyzed by esterases in our blood, and now you have fluphenazine released slowly over time. So with these two formulations, so the fluphenazine enanthate or Prolixin, right? So that's the trade name, enanthate. So this is once every 2 weeks. So basically, patients just need to go to the clinic and receive the injection once every 2 weeks. And then for this one, decanoate, it's once 3 to 4 weeks. So this can be given by IM or by sub-Q, right? So once it's injected, it's going to slowly leak out from the injection site because it's a depot formulation. And patients then just need to go, just receive the injection every 3 weeks or every 4 weeks, right? So this was approved, the last one here was approved in 1972, and this is in the US. In other countries, they have used this, right, enanthate. So in the US, we're talking about this decanoate. The other one is more in the European countries and other countries. So this is the depot formulation. The prodrug, in this case, the T half of the prodrugs in the formulation, we're talking about 163 to 132 hours. So it's going to be much longer, and also because the drug are slowly leaked out, so slowly hydrolyzed. So over time, so this ester derivatives have long duration of action as compared certainly to the HCl salt. They are used for the parental administration, long parental administration for the chronic treatment of, like say, this chronic schizophrenia. So this solved the problem with adherence in patients, right? So they can continue to maintain their drug molecules in their system rather than having them skipping doses if they're given orally multiple times a day. So this is the fluphenazine, the prodrug form that revolutionized the treatment and management of schizophrenia. And you'll see probably multiple other forms of prodrugs and also formulation strategies that have been able to extend the duration of action. So you'll see more as we continue the discussion. So this is the first one that was approved in the 1970s. And then we are going to see more like in the newer drugs that you'll see later on. So the next drug molecule is called isosteric phenothiazines. So isosteric, so that means something that has changed in the structure, but very much still the same. It's like a phenothiazine derivative. So what you see over here is thiocysteine, thio, so that means acid sulfur. And then in the nitrogen originating in the phenothiazines, that nitrogen has been replaced by sp2 hybridized carbon. Right? The idea here is to really try to maintain the planar geometry of the phenothiazines. The nitrogen in phenothiazine would still be an sp2 hybridized nitrogen. Right? So it's a planar geometry with the nitrogen pair of electrons overlapping with the p orbitals, the p orbitals of the phenyl rings, the pi electrons in the phenyl rings. So you are seeing trying to maintain a planar geometry, right? So, but then this is what's called bioisosteric replacement. one of the drug design principles that I use to come up with new drug molecules that still have similar or could be better activity as compared to the original compound, original drug. So this is a bioisosphere of phenothiazines. So the rest of the structure very much similar, right? Between the ring and the nitrogen, you still have 3 carbons, right? That's what usually requires between for the phenothiazines. And then at the 2 position, right? At the 2 position, you have a sulfonamide. It's also an electron withdrawing group. It's a sulfonamide. And of course, introduction of the double bond, you're going to have cis and trans configuration, right? The ones on the right-hand side, this is the Z configuration, is the more active isomer. So that's what's used in the clinic with the Z configuration. So that means this group, which is larger than the hydrogen, and also this group here is larger than this part, are on the same side. So that's the Z configuration. So it's a bioisosteric replacement. In terms of its use, very similar to the other phenothiazines. Earlier, the drug molecules. So it's going to work on the dopamine 2 receptors with some other activities, maybe on the histamine and also serotonin receptors. So it is used as an antipsychotic. So the next drug molecule is structurally very different from the phenothiazines, but its clinical profile are very similar to the phenothiazines, right? So this is what's referred to as molindone. Molindone with the ring system, you have like a 6-member ring fused with a pyrrole, right? So this, if it's aromatic, it would be indole, and then it's linked to a morphin structurally very distinct from the other phenothiazines or the other like the antipsychotic agents. So the Molbane is trade name, but this trade name has been discontinued, but there are more generics in the market that uses, of course, molindone as the generic name. Molbane, the brand name, has been discontinued. So in terms of its use, in terms of mechanism of action, is unknown. So could still be the dopamine 2 receptor antagonist. As I said, the clinical profile of this drug molecule is very similar to the piperazine, right? You do have to the piperazine phenothiazines. So the earlier ones was piperazine phenothiazines. This is used as an antipsychotic for the management of schizophrenia, and very little of it is eliminated and changed. Very extensive metabolites, multiple metabolites, because of the various oxidative metabolism, and there is a number of 36 different metabolites from this drug molecule. There's only about 2 to 3% of the drug eliminated and changed. So this is a unique structure that belongs to like the indoles, and of course you have also CO double bond, right? You have a double bond in the ring, another double bond here, that would be indole. So it's more or less like a dihydroindole. If you have the double bond here, but then if you have this one, would be tetrahydroindolone. So there are 2 other drug. Let's look at the other class of drug molecules that also have been has a general structure. So this is what's called butyrophenols. So butyrophenols has the general structure. This is basically butyro means 4 carbon. So what you have is in here you have 3 carbons on this side of the carbonyl, right? 1, 2, 3 carbons, plus the carbon in the carbonyl. You have 4 carbons. So that's called butyro or butyro. Butyrylphenol, because on the left-hand side, you have an aromatic ring, that's usually a benzene ring. So that benzene ring will give you butyrylphenols, right? So this is the general structure of butyrylphenol when you have a ketone. And then you have, on the right-hand side, you have a six-member ring with one nitrogen in the ring system. That's piperidine, right? Piperidine is two nitrogen with piperazine, but this is piperidine at the 4 position. You have another arrow group, right? So you have another aromatic ring system attached to it. So in general, butyrylphenols are more potent than phenothiazines, or more potent than phenothiazines or the isosteric phenothiazines. They can cause greater CNS side effects because the activity we are talking about is in the central nervous system. More potent could lead to more side effects, more CNS side effects. But then the peripheral anticholinergic side effects, we have less as compared to the phenothiazines. So between butyrylphenols and phenothiazines, butyrylphenols are more potent, can have more CNS side effects, but less peripheral anticholinergic side effects. So you look at the structure of butyrylphenols, as we mentioned, you have a butyryl group, you have a phenyl ring, but then actually this carbonyl is not really required, right? So you can see the next structure under it has 2 arrow groups attached to a carbon. You no longer have the carbonyl, right? So it's a diarrow methyl replacing this arrow ketone. So it's being replaced. That will still give you an active antipsychotic agent. So that means the ketone is not really required for activity. And then on the right-hand side, you have the piperidine, and that, in this case, still the same. You have the arrow system. So in terms of SARs, so it is believed that the drug is also mimicking dopamine, right? So you can see dopamine is kind of overlaying on top of the right-hand side of the butyrylphenols. You have the benzene ring, the arrow group, arrow 2, and then you have a 6-member ring, the piperidine, the nitrogen kind of mimicking of the nitrogen dopamine. So these drug molecules would still work on the dopamine receptors, right? We're talking about probably blocking the D2 receptors and have antipsychotic activity and also antiemetic properties, right? D2 is associated with nausea and vomiting. So as you'll see, there are drug molecules in this class that are used mainly just for nausea and vomiting, post-operative or more nausea and vomiting, or even chemotherapy in terms of nausea and vomiting. So in terms of the SAR, again, so the arrow ketone is good for activity, but can be replaced by the diphenyl methyl group. Fluorine, you can see drug molecules on the aromatic arrow 1, you can have a parafluorine substitution that usually with increased antipsychotic activity. And fluorine, of course, in the para position will also restrict or delay the metabolism, right? Or limit the metabolic reactions associated with para-hydroxylation reaction. So the aromatic rings on the right-hand side is important for activity as it's mimicking the aromatic ring in dopamine. And the aromatic ring should be directly attached to this carbon, or only can be separated between the ring by 1 atom away. So you'll see structures that have this phenyl ring another atom away inserted between the phenyl ring and the 6-member ring. So the mechanism of action, again, is most likely working on the dopamine D2 receptors. So the first drug in here is haloperidol. So haloperidol have the general structure. You have a fluorine in the para position that we know enhances antipsychotic activity. You do have the ketone, so this is butyrylphenol, and you have a pyridine, and then another aromatic ring in the para position of that aromatic ring, benzene ring, has a chlorine substitution. And then you have a hydroxy, right, attached to this carbon at the 4th position. So looking at this structure, right, so the half-life, first of all, the half-life of this drug molecule is about 12 to 38 hours. So for this drug, in order to be used to treat schizophrenia or other psychotic disorders, we are looking at 2 to 3 times a day by oral route or by injection, right? So you're going to have to administer the drug 2 to 3 times a day. So the half-life is about 12 to 38 hours. So in terms of metabolic reactions, so this hydroxy, right, is a handle for conjugation reactions. So you can have sulfation or glucuronidation. So we're looking at probably 50 to 60% of the drug would have a conjugation reaction and help eliminate the drug molecule from the system. So that's 50 to 60%. And then you can have dealkylation, so break this into 2 halves. You're looking at 20 to 30% of the drug molecules going through that route. And then you have a ketone, right? A ketone can be reduced. This is one of 3 functional groups that can be reduced, that can give you the alcohol reduction. So that's about 23% of the drug molecule that can go through the reduction. So you can see you do have extensive metabolism of this drug molecule. That gives you a half-life about 12 to 38 hours. As we mentioned earlier, we cannot really force a schizophrenic patient to take these drugs on a regular basis. Now we do have hydroxy already in the drug molecule, right? So we can attach something to it, fatty acid. So what you are looking at in this case, we are looking at a decanoate. So 10-carbon fatty acid attached there that informs an ester bond. Now it's a prodrug. We can suspend the prodrug because it's not going to be that soluble or dissolve. It's not going to be soluble in water. We can dissolve it in sesame oil, right? So it's an oil formulation. And then we can do the IM injection. And this drug is given on a monthly basis. So every 4 weeks, patients can just go in and receive injection, and then the drug is going to be slowly released from the injection site, and then the esterase is going to hydrolyze the decanoate and remove the fatty acid. Now you have haloperidol that's going to work on the patient's basically control the schizophrenic conditions. So this drug is used as an antipsychotic and including schizophrenia, for psychotic disorders, including schizophrenia, and also for Tourette syndrome. Tourette syndrome and in the control of the tics and vocal utterances from these patients. So the mechanism of action of this drug molecule is on the dopamine receptors, right? So it's actually known as the dopamine D2 inverse agonist. So inverse agonist is further the effect of the antagonist, right? Antagonist is just drug will bind to the dopamine 2 receptor and block the binding of dopamine. But in terms of this drug, this actually goes even further and produce the activity, the opposite of a dopamine on its dopamine 2 receptors. So dopamine, when it binds to dopamine receptors, will decrease cyclic AMP concentration inside the cells. But in this case, when this drug binds to the dopamine 2 receptors, it actually increases cyclic AMP concentration. So that's why it's also referred to as an inverse agonist. So this is haloperidol, okay, with the parent molecule that's given multiple times a day, but you do have a prodrug form that can increase the duration of action after IM administration. Remember, it's IM, intramuscular administration, on a monthly basis. So the next drug molecule is droperidol. So droperidol, if you look at the structure on the left-hand side, you have the same kind of parafluorophenol ketone, right? So that's the same. So you have the fluorine that gives you enhanced antipsychotic enhanced activity, and is binding to the D2 receptor, and also protect the phenyl from metabolic hydroxylation, just like the drug on the top. When you don't see metabolism on this phenyl ring, you don't see metabolism on this phenyl ring either, because this has a chlorine substitution. Right-hand side, we have a chlorine substitution. Both fluorine and chlorines are electron withdrawing functional groups. So on this drug molecule, you do have a fluorine. On the right-hand side, the difference is you do not have a phenyl ring directly attached to this carbon. You do have a phenyl ring, however, right? But it's one atom away. So that's why I mentioned earlier that this one atom, you cannot have more than one atom. But here you have a nitrogen between the ring and also this phenyl ring. So this is phenyl fused with two nitrogens, right? That would be benzimidazole. And then because you have a ketone, benzimidazolone. That's the right-hand side of this drug molecule. So you have a double bond. That's another feature of this drug molecule, a double bond. You have a phenyl ring. So in terms of metabolic reactions of this drug molecule, the benzene ring now on the right-hand side has no electron withdrawing group on it. You're going to have oxidation on that phenyl ring, right? You can have hydroxylation here, so that can be oxidized. And you have the double bond. You can form oxide, or you can get rid of the nitrogen through more or less like hydrolysis. And then you, of course, have the CO double bond. That's a ketone that can be reduced. So there are extensive metabolism of this drug molecule that gives the drug a half-life 134 minutes. So only about 2 hours of this drug molecule. So this is not going to be very useful for schizophrenia, right? So we don't want a drug that only controls the condition for about 2 hours. So this drug is actually more for nausea and vomiting, right? So this is injection only. So this can be injected by intramuscular injections, or can be IV, slow IV injection of this drug molecule into the patient's system. And then this can, for the reduction of nausea and vomiting in surgical procedures, like after general anesthesia, or for after diagnostic procedures. And this drug can also be given IV as an antiemetic for cancer chemotherapy, right? Cancer chemotherapy is known to be associated with nausea and vomiting, and that can be controlled also by this drug molecule. So droperidol is not used as antipsychotic. It's mainly due to the short half-life, right? Antipsychotic activity is chronic condition. you want to continuously maintain the drug concentration. So this drug is too short, has too short a half-life, so it cannot be used that way. So it's a potent dopamine 2 receptor antagonist, and with some histamine and serotonin antagonist activities added with this drug molecule. But it's used as an anti-emetic, so it's droperidol as an anti-emetic drug molecule. So the next drug molecule is pimozide. So pimozide, now you have diphenyl methyl replacing the phenyl ketone, right? So this is the other drug, the structural feature. And then on the right-hand side, it's similar to droperidol and without the double bond in droperidol, right? So this is the pimozide. Pimozide, with this change, you do not have the ketone, and you do have metabolism that can happen to this. And also on the phenyl ring, you still have possible hydroxylation reactions. So it is extensively metabolized. So the half-life of this drug molecule is about 29 hours plus minus 10-hour half-life, because between people you do have a variable degree of metabolism. So we are looking at about 19 to about 30, 40-hour half-life of this drug molecule. So this drug is mainly used for the suppression of motor and phonic tics in Tourette disorder. Okay, so Tourette disorder. So it is less used as an antipsychotic, probably because of the requirement of using this drug multiple times a day. So this is pimozide. So next page we have some miscellaneous antipsychotic agents, 2 of them. So we're looking at lithium. Lithium have 2 forms. One is lithium carbonate. The other one is lithium citrate. Right? So basically what's active in here is the lithium ion. Right? Lithium ion can be absorbed actually and then distributed to the central nervous system. They work by increasing norepinephrine reuptake. So you have less of norepinephrine in the central nervous, in the synapse, and also increasing serotonin receptor sensitivity. So it's a very different mechanism, no D2 activities related to lithium ions. And this drug is indicated for the treatment of manic episodes of bipolar disorder, and as an inorganic ion, right? So you would see this lithium ion eliminated through urine. So when it eliminates through the urine, because it's a positively charged cation, what do we have in our body a lot? Like sodium ions, right? Sodium ions, we usually want to reabsorb sodium ions so we can keep sodium ions in our system. We don't want to lose too much. But in this case, because the lithium ions is similar to sodium ions, can be reabsorbed and so on. So it actually inhibits reabsorption of sodium ions. So when people take lithium drugs to treat the bipolar disorder, they might lose more sodium ions in the process. And of course, sodium ion depletion. So that's something to keep an eye on when patients taking these lithium for the bipolar disorder. So this is what I want to talk about in terms of lithium ions. So it's very effective actually for the manic episodes of bipolar disorder. So that's the indication of these 2 different sort forms. And of course, with the lithium carbonate is the most commonly prescribed among the two lithium salts. So the next drug molecule is loxapine. So loxapine, if you look at this loxapine, you have a three-ring system, and this is very similar to a drug molecule we discussed last semester when we talked about TCAs. So you do not have this methyl group on the top right-hand corner, and it's amoxapine. It's one of the TCA we talked about, so it's going to be like antidepressant. So this drug molecule with the methyl group here, and then with, of course, the three-ring system, the nitrogen and oxygen and the chlorine at this two position. So this drug molecule is used for schizophrenia, because the methyl group on the top can be demethylated. Once it's removed, it's a TCA amoxapine. So a TCA amoxapine. So how this drug actually manages to treat as an antipsychotic for psychotic disorders is unknown how it works. So it's probably various systems we are looking at in the central nervous system, similar probably to TCAs in terms of modulating the activities of neurotransmitters in the central nervous system. So that's loxapine, very similar to amoxapine, with just the additional methyl group. So what we have discussed so far, we have all the drugs that we talked about, phenothiazine, butyrophenols, and then the lithium, and also loxapine. These are drugs are considered typical antipsychotics. So far from here, right, to earlier, these are all called typical antipsychotic. So that means they are at the time, they are the ones that are used as for the treatment of psychosis or psychotic disorders. They are often associated with what's called extrapyramidal symptoms, called EPS. Extrapyramidal symptoms. So EPS, and these are usually movement disorders, including, for example, tardive dyskinesia. So that would be TD, tardive dyskinesia. So this is one of the side effects associated, more commonly associated with typical antipsychotics. And also they're called first generation antipsychotics. They are relatively older drugs, and they only treat, if you look at the next page, so most the antipsychotics we discussed so far, they only treat the hallucination aspects of schizophrenia, which is considered to be the positive aspect of schizophrenia. Positive here doesn't mean it's good, right? It's not the good side, but it's the hallucination, more kind of excitatory, positive effects of the schizophrenia. That can be controlled by these typical antipsychotics. But they don't treat negative aspects of schizophrenia, which is withdrawn from society, right? So that's the negative. So the negative aspects have to be treated as well, and then those are the ones treated by the second generation antipsychotics. So what we are looking at now, from now on, so we're talking about atypical. atypical antipsychotics, or second generation. So from now on, we're looking at the second generation antipsychotics. And first, typical antipsychotics, they treat only the positive aspect of schizophrenia. They are often associated more commonly with the movement disorders, like the extrapyramidal side effects. Those are the ones that have movement disorders. So now we're looking at newer drug molecules that can treat both positive and negative aspects of schizophrenia. The drug that does this, the first one, is called clozapine. So this is the first one. Clozapine is the structure shown, very similar to the structure of loxapine, right? So clozapine, the difference is the oxygen in this loxapine is being replaced by nitrogen. And then at this position here, and you chlorine from the 2 position move to the other side, right? So that's the difference. The rest of the structure is very much the same. So this is a drug relatively older among the second generation. So this drug was approved in 1989, the first atypical antipsychotic. Mechanism of action is still unknown. There is a significant risk of this drug molecule having agranulocytosis. That's the problem with this first drug molecule, right? So this is really a sharp drop in white blood cells, and that can be fatal if not treated properly. So that's a very important effect, the side effect of this drug molecule. But this is one of the first second generation drug, and this drug has a low risk of the EPS symptoms and the tardive dyskinesia symptoms, movement disorder. This is considered probably the lowest risk of having those movement disorders as compared to even newer second generation antipsychotics. So it has its advantages, but the problem is agranulocytosis, right? So that's a very serious side effect of this drug molecule. So let's look at some of the newer second generation antipsychotic, or the atypical antipsychotic, right? So the first of these is risperidone. So risperidone and the structure below this belong to the same class. So on the left-hand side, you have a phenyl-rin fused with the 5-member ring system with the oxygen and the nitrogen next to each other. So this is the benzoisoxazole. Right? So this is benzoisoxazole. So these two can be classified as benzoisoxazoles. So the trade name for this drug molecule is risperidone, right? So this is the trade name initially given to this drug molecule. So this drug was first approved in 1993. 1993. This is a J&J drug. It's an oral solution or disintegrated tablet. So basically, this drug molecule it's taken on a daily basis, right? So with this particular drug molecule. But this drug is known to have a metabolism that introduces a hydroxy group. And this has turned out to be an active metabolite. So the half-life of this drug molecule is 3 to 14 hours, but relatively short. So risperidone itself, it has to be taken multiple times a day. So there is a prodrug form, not a formulation, not a prodrug, of the called risperidone constant. So this is the brand name. So basically they have encapsulated this drug molecule, Risperdal itself, or risperidone, the generic name, in a polymer. So the polymer is referred to as PLG copolymer. So it's polymeric, right? Polylactic glycolic acid polymers through ester bonds between two carboxylic acids. So it's cross-linked, and then of course the drug molecule is embedded in the polymer, and this then is implanted in the patient's system, right? In the patient's IMs through intramuscular administration. So this is micro-encapsulated polymeric formulation with drugs embedded in there. And the polymer is going to be slowly hydrolyzed over time. As the polymer is hydrolyzed, the drugs are exposed and released into the system. So it's not a prodrug form, but it's a formulation approach to slowly release the drug molecule over an extended period of time. So this drug molecule then can be given, let's say 25 milligrams over 2 weeks. So every 2 weeks, patients can just go in and receive an injection of 25 milligrams, and then the 25 milligram is slowly leaked out as the polymer is being degraded over time in the patient's system. So this is the prodrug, not prodrug, this is the formulation approach to extend the half-life of risperidone. But we just mentioned risperidone can be oxidized to introduce the 9-hydroxys, right? So this is the hydroxy metabolite, which is active, and that actually turned out to be the drug that's used next. So it's called paliperidone. Paliperidone is the generic name, and then you have the brand name of this drug molecule called Invega. So Invega is the brand name. In this case, Invega is first approved as a tablet. So in this tablet, it's actually a hard shell tablet, right? So the tablet does not dissolve, disintegrate, but then the drugs are inside the tablet. It will leak out over time, even though the half-life for paliperidone, in this case, the metabolite, paliperidone, the half-life is 23 to 30 hours. 23 to 30 hours, longer than risperidone. But Invega is embedded inside this hard shell, non-absorbable tablet, so it slowly releases the drug molecule. So that's for once daily dosing. Right? So this is a tablet that can be given to the patient. Will eliminate as a tablet form, but the drug's already released over the time that patients have in this tablet inside the GI tract. So this is the Invega with once daily dosing. But Invega also has this hydroxy group, right? So hydroxy group can then be acetylated. So in this case, what they did is using palmitate. So palmitate, of course, is palmitic acid, which is the 16-carbon fatty acid. 16-carbon fatty acid. Longer than decanoate, right? 6 carbons longer than the decanoate. So this drug then, once it's acetylated, is going to be highly lipid soluble. So then it's a prodrug form. So in this prodrug form, it actually forms nanocrystals, and the crystals can have different sizes, and then they can suspend in actually an aqueous solution. So there is like different forms, different injections patients can receive. So Invega, so this is the same brand name, Invega Sustainer. So this is the trade name, Sustainer. So this is once a month injection. Once a month injection. So this is the Sustainer. And then if you increase the size of the nanocrystal and also have more of the drug, right, per injection. So you are going to have Invega Trinza. Okay, so this is another trade name. So this TRI, right? What does that mean? 3. So that means it's going to be given every 3 months. So extended release formulation. And then you have also another one, different formulation, even larger size, say larger doses, right? Larger doses. So this is half HAF euro. So this is once every 6 months. So that means patients just need to go in to receive the injection twice a year. And then the patients can have this drug molecule over the extended period of time in the patient's system. So in Invega you have, right, how many different formulations? You have formulation that gives you the QD administration once daily, and then you have these 3 additional co-drug forms that have different sizes of crystal that can be suspended, and it slowly dissolves and releases the drug molecule. And you can have once a month, once every 3 months, or once every 6 months. So this is the paliperidone in terms of the hydroxy metabolite of this risperidone. And of course, this are all marketed through J&J, right? So they have invested certainly in co-drug forms, in different formulations, so they can give long duration of action, from once per month, once a day, to once per month, every 3 months, and once every 6 months. Okay, so I'm going to stop here, and then
D2 is what? So that's right.
Yeah.
You're so clumsy. Oh my god. So did he? What do you mean shut the hell up? You can't even say the thing. Dude, how the fuck the hell? So Bernardo, come with me.
tomorrow, and also remember, usually I post after Thursday's lecture, the notes that I have, basically these slides, like that, with the notes written in class on campus. So that should help you prepare for the quizzes.
What?
For one more quiz on Monday.
What you say?
The last
I did it for you. I did it for you.
Ready? Yeah, it's like, you did it for him, no?
Yeah.
Don't matter, bro. We're not gonna do that. Generations have to suffer the whole year. Yes, they do. What's the point? Let's hypothetical circle of turns. Yeah, you want worse farmers? Oh, let's just take away everything that makes San Francisco parts. Yeah, I had a meeting with her last night. I finished the scaffold replacement. So like, I'm done, yeah. About the what? So the scaffold replacement is the one where you select the atoms that you want to change, right? So you would just like, you would select the groups. Oh, sorry, when you said database, I thought you were talking about like the previous stuff. So then what happens is then you just use the parameters that it gives you. So like TPSA, like you just leave that 40 to 140. There's another thing before the, I think it's like the S or something, there's some other value. Basically that the parameters are there to like align it to Lipinski's like rule 5. So you could just keep what it's there originally, like the weight you could just keep like less than 500. So for me, basically there's gonna be a part of the molecule that's like the main part, like the foundation you want to keep.